Good afternoon, Dr. Inkster. Mr. McIntosh.
Thank you. Dr. Inkster, we can go back to your S-bar of June 16. That's bundle 4, page 234. It occurred to me that there's probably one extra question I need to ask. If we could look at the bottom half of the page, please. 234. No, bundle 4. Page 234. Sorry, page 52. My mistake. Now, this is the S-bar we discussed before the lunch break, in which you react to the air change rate news that you received from Mr. Parry. And what I notice is no discussion of the impact on Ward 2A in the Children's Hospital. Am I right in realising that this isn't addressed in this S-bar?
No, it's not. That information came later. There is an email somewhere where I asked him to confirm whether or not that was the case in the Children's Hospital as well.
So you didn't draw the conclusion from the Parry email and from the ventilation strategy document that it applied to the Children's Hospital too?
No, I didn't, I guess because they were two separate buildings. So I wasn't sure if the strategy was universal across both of them. So I wanted confirmation from him.
So this is about, we should read this as being about the adults?
This is about the adults.
Okay. We can take this off the screen.
Now, there may be an issue about not hearing. There's certainly an issue here about not hearing. Miss Laurie, would you like to...
No, it's been resolved, my lord.
It's
the
been
screens
resolved.
are now on. So
right.
we've...
Well, thank you for the intervention, even though I didn't actually hear what the intervention was.
So now that we have the screens appearing for the benefit of core participants, counsel and solicitors, if we return to the subject of this S-bar of the June 2016, page 52 of bundle 4, if that's about the adult hospital, did you do an equivalent S-bar about the children's hospital?
No, I didn't. I gave the same instruction to infection control, but I didn't do an S-bar.
So what would that instruction have been? The one about the 2 hours window?
Yes, the same.
So if we go back to our conversation about neutropenic wards, and indeed your later concern about patients not staying in their rooms effectively, well, I realise that's a shorthand, what would be the effect on the, what would be the impact in terms of risks to patients in 2A outside the isolation rooms of an air change rate of 3 or potentially a little bit less air changes per hour in Schiehallion?
So there wouldn't be as rapid dilution of airborne contaminants. So where that would be important would be particularly in relation to outbreaks of respiratory viruses. So for example, if a staff member went into the room and they coughed.
But what about if a staff member just walked along the corridor and they coughed?
It would depend on the pressure of the rooms.
You see, the concern that I'm trying to capture is that if we go back to the adult hospital just for simplicity, and you take a general ward, like 6A was then a older person's ward. You're nodding. Again, remember yes. The transcript person. The rooms are separate, but there's no pressure differential, and there may not be a seal between the room and the corridor. Have I got that right?
Yes.
Right. And so if you've got 3 air changes an hour in the rooms and 3 air changes an hour in the corridor, one risk is what's happening in the room, and that's the 2-hour wait.
Yes.
Yes. And the other risk is that something is in the corridor and that gets either into the rooms or a patient meets it when they leave their room to go somewhere else in the ward.
Yes.
Right. Now, in that general ward, using 6A as an example in 2016, apart from the 2-hour gap instruction that you've put in the S-bar, what are the other risks to general adult patients, so it's outside ward 4B, 4C, of only having 3 air changes an hour?
So they're at risk of a greater risk of infection because you don't have the dilution of airborne contaminants.
But they're not neutropenic or anything close to that normally.
No, but you don't have to be neutropenic to acquire a respiratory virus.
So you're worried, that would be your worry.
Uh-huh.
If we take that over to ward 2A now,
Yes.
you've got the 4 or 8. At this point, how many working isolation rooms were there in ward 2A?
Sorry, what year is this now?
2016.
2016, there would have been 8.
Right, so 8 working isolation rooms. So in those rooms, the patients have got HEPA filters, yes?
Yes.
They've got a positive differential between the room and the corridor?
No, because they were still PPVL rooms at that point in time, so a positive differential between the anteroom and the corridor.
Are they sealed?
Yes, they had been sealed. That work had been done.
And they have HEPA filters?
Yes.
And what's the air change rate in the 8 isolation rooms?
10.
10. So that risk is unaffected by your understanding. The risk in the isolation rooms is unaffected by your understanding about the general ventilation. Am I right?
There's still a risk because these patients are so vulnerable, even with an air change rate of 10,
Yes.
that they might be susceptible to a respiratory virus from a staff member who's coughing. But that risk is mitigated to a degree with a higher air change rate.
But your understanding of that risk is not affected by you learning of the 3 air change rate in the rest of the hospital?
No, not
No.
for those rooms, no.
No. So if you then take the corridor in 2A and the other rooms in 2A, what's the risk? What risk is discovered, as it were, in the corridor and in the other rooms in 2A when you realise that it's only 3 air changes an hour as opposed to 6 in the rest of the ward?
So obviously we discover the risk of slower dilution of airborne contaminants. And in response to that, around 2016, when dealing with the Aspergillus incident, we looked at the pressure in the rooms and it was confirmed at the time of being +2 pascals, which isn't obviously anywhere near 10, but it is a degree of positive pressure. It wouldn't be possible really, I don't think, to go above that because of the situation with chill beams in the ceiling. So there was a degree of positive pressure.
So you took some reassurance from that?
I took some reassurance from that. The other thing that we did was upgrade the filtration, I think as close to HEPA as we could, but we couldn't HEPA filter. So there was some adjustments, but I accept that those weren't,
Right.
optimal. But we did put some mitigation in place.
We don't find them in an SBAR, but that's an instruction you gave.
Yeah, so there's discussion, I think, in minutes around an Aspergillus meeting in 2016 where Ian Powrie is going over the ventilation issues and we talk about pressure. And I think there's a series of emails before that where my colleague was involved as well, and we discuss the positive pressure.
So some steps are taken?
So some steps, yes, but not in the SBAR.
SBAR, okay. This is an adult SBAR.
Yes.
Well, that's very helpful. What I want to do now is to move on to thermal wheels, which you deal with on page 133 of your statement. And this is 133, paragraph 395 and 396. And you have in 396 your understanding that there's a risk of a mixing of supply and extract air, although it's likely to be a small amount, and such mixing would not be desirable in housing immunosuppressed patients. Why do you say there would be this risk of mixing?
That's what I was told at the time. I'm not a ventilation engineer. I was told that at the time when the Innovative Design Solutions report was released, that there was a theoretical risk of mixing the dirty extract with the clean supply.
And are you aware that NSS plans to undertake a literature review on this topic?
I'm aware that it's on the list of topics for research because I've got the output from various research workshops and thermal wheels are on there. I'm not familiar with what stage that's at, but yes, I'm aware they plan to do work on that.
I'd like to move on.
Sorry, again, just that I'm following that. That's on RHI's or is
Yes, NSS is research.
it? So it's
NSS.
NSS. Right. Thank you.
I was proposing to move on to the Elizabeth Kingia Miracola incident in 2017, which you discuss on page 174 of your statement. Now, you've reached a conclusion in this that the risk of the link to the environment is highly likely. You see that link to environment highly likely?
Yes.
What I want to understand is, you've also said it's a waterborne organism.
Yes.
Where was this water coming from in this hypothesis?
Two possibilities, the water from the taps or the water from the chilled beams.
Now, by the point we
Condensation.
get to, the way you've just explained is that in April 2016, you hadn't realised what a chilled beam was.
Yes.
So I'm therefore right in thinking that before April 2016, there were no reported instances of condensation or leaks from chilled beams that you were aware of.
Not to me, because up until that time I was really just covering regional and the Beatson, so
Right.
not before I took on the lead ICD role. I wasn't aware.
What were you learning when you took on the lead ICD about chilled beams as a source of water?
When I got the information from Mr. Powry, I was aware of how chilled beams functioned, but I wasn't necessarily aware of this phenomenon of condensation happening, because that should be, there should be, I think, what's called dew point control.
And was there dew point control on these?
I believe there was not. I believe that was one of the issues that was uncovered.
So if it's coming from the chilled beams, in your mind, what did you do about that in March 17, following this PAG?
We tested the chilled beams, we swabbed them, and we tested the outlets, and we didn't recover the organism. But Elizabeth Kingia Miracola, at the time of this incident, there had been communication from, I can't remember exactly who, around identification of this bacteria. Labs were misidentifying it as another Elizabeth Kingia meningoseptica, and only reference labs could identify Elizabeth Kingia Miracola. So it was challenging for a normal lab, well, impossible at that time really, for a normal lab to name Miracola. It had to go to a reference lab. So thinking then about water testing, it would be highly unlikely that at that point in time we could have actually assigned a name to that organism. Am I explaining this?
No, you are. So basically, you have the Elizabeth Kingia Miracola in the patients,
Yes.
and you get that identification from the reference lab.
Yes.
But when the domestic on the lab at the I'm assuming it's the GRI lab.
Yes.
When it analyzes the water, it can't the sample swabs from the beams or the water supply. It can't identify Miracola because it doesn't have the technology.
It would have been unlikely to at the time, and there was quite a lot of learning from this incident. So if we take it forward to 2021, 2022, myself and the team at Glasgow Royal Infirmary and UK HSA Water Labs got some funding to develop water testing methodology for some of these gram-negatives, and we put Elizabeth Kingia on that list, and we tested and developed a methodology for 10 Elizabeth Kingia Miracola isolates. So this issue stuck with me, and we now have a methodology that could be used and would hopefully detect it. But at the time, it is possible that it was what we might refer to as an unidentified gram-negative.
So how do you respond? I mean, it's not only just this one, but it applies to a number of other cases you've discussed, to the idea that if there's not a link in terms of genetic link between the sample and the patient and the sample in the environment, one should exclude an environmental source? Because that seems to be the position of the Health Board.
Yes, that's what we were doing. We were screening for an environmental source.
But if you didn't find the link, so if you found a sample in the patient of this species, a sample I know you didn't on this occasion, but if you found a sample on the chill beam or in the water supply, if I understand the Health Board's position correctly, it is that if you can't directly connect these two sources with the same very closely related bacteria, there isn't an environmental connection. It's an exclusion. Do you agree with that or disagree with that?
No, I don't agree with that. I mean, outbreak management is about, and hypothesis generation is about plausibility. Is it plausible, first of all? It was plausible from the information that we had. We had a known waterborne organism, we had leaks from a chilled beam, and, is it probable? Well, highly probable that that's the cause. Outbreak management is very uncertain at times, and we don't always prove a link. It's a very, environmental sampling has many pitfalls. I've just described one of them. It is very difficult when you've got such a large surface area to cover with swabbing. It is very difficult at times to actually, bacteria adhere to surfaces, and there can be problems actually getting them off the surface with the swab. So the yield is sometimes quoted as being as low as 25%.
So you're only getting a quarter.
So you're only getting a quarter, and then when you get to the lab to get the bacteria from the swab onto the agar plate, that's another 25%. So I don't think that you can rule out an environmental connection just because you've got negative environmental sampling results. It's a bit like searching for a needle in a haystack. If the results are positive, then that's great. That really supports your hypothesis. But I don't believe that you can exclude an environmental source, particularly when you have, an epidemiological link in time, place, and person, an excessive number of cases, and you've got a very plausible, unlikely source. And the name of that organism told us so much because it's Miracola. It comes from the space station Mir. It was identified in condensation, and you have condensation forming on a chilled beam. So there's a high probability that that was the cause. We just weren't able to prove it due to pitfalls in environmental testing.
I'm going to do this out of order, but it seems a good place to do it. Could we go to page 218 of your statement? To paragraph 656. Now, you touch the bottom of this page in the context of a different IMT later on about how you select samples from biofilms. Now, I appreciate Elizabeth wasn't involved in a biofilm. It's a different source.
Yes.
It's the chilled beams. But since we're talking about this topic, let's explore it a bit further. If you are looking at a potential environmental source in a water supply, why do you say that biofilms are complex and have multiple strains of bacteria?
So biofilms in a water supply, hospital water, it's not sterile, so there are low levels of bacteria in hospital water supplies. If the system isn't adequately maintained, doesn't have appropriate control measures in place, then biofilm develops and that will continue to become more complex, and that was certainly the case in the Queen Elizabeth. Because we had, problems that date right back to the installation. I think it was pre-filled a year before the hospital opened, so many, many years for this biofilm to accumulate. And over time, it will become very complex with lots of different types of bacteria and lots of different strains of bacteria.
When you say this biofilm, I'm assuming it's not one object, is it?
No. It's a complex community of bacteria, and it's like a slime lining all the pipes. And it can be very difficult for disinfectants to penetrate the biofilm. That's one of the challenges when biofilm develops, is that they can become resistant to disinfection.
And in terms of quantity of biofilm, I doubt anybody has ever scraped every piece of biofilm off an entire hospital water system and weighed it. But in terms of area or volume, what should we be conceptually thinking in order to understand the biofilm at the Queen Elizabeth that's in existence in 2016?
I think it would be very extensive. I think in a well-maintained water system, you can have a localised issue to the outlets, and you can have relatively limited formation of biofilm, and that might occur because of poor tap maintenance or lack of flushing or practices, inappropriate practices around the sink. And in that situation, when it's limited to maybe 1 or 2 outlets and you've been doing regular water testing, the biofilm might not be so complex. And quite often in those outbreaks, you are able to get a match between the patient and the strain in the water because the biofilm hasn't had time to develop. But in the situation with the Queen Elizabeth, you've got many years for that biofilm to develop and extensive pipe work. So many outlets which weren't being maintained. So that biofilm is likely to be very extensive and very complex with multiple different types of bacteria and multiple different strains of bacteria as well.
So you provided the inquiry with an article, an editorial you wrote for the Journal of Hospital Infection in 2021, which is in bundle 19, page 1232, document 41. I'm not going to go through this because, like the Journal of Hospital Infection, it's very small text, there's an awful lot of words. But if we read this, to what extent does this sum up your understanding of this issue about biofilms and complexity and diversity?
Yes, it does.
Right. Now, we'll read that, and I think Dr. Mumford and Mr. Dempster have read it. But the reason I wanted to put it up on the screen and talk to you about it is, what evidence do you have that the biofilm in this hospital was as complex as you say it is?
The evidence from that comes from what we were growing in the water in terms of the different organisms and the diversity of the different organisms.
We can take this off the screen, by the way.
And also what we were growing in the patients and the diversity of those. And the fact that when we were doing typing, we were detecting multiple different strains of bacteria. And if you were to read the literature on waterborne outbreaks, you will find that more complex contamination incidents, so not localised to the tap so much, but further back in the system, are what we call polymicrobial. So that's multiple different types of bacteria, and polyclonal, multiple different strains. So that is described in the literature. There are outbreaks of Stenotrophomonas, for example, where people have found 5 different strains in patients, 3 different strains in water. They don't all match up. But what does happen is when they put in the control measures, they bring the problem under control. And it goes back to what I'm saying about the challenges of environmental sampling and not taking enough colonies from the plate to do your typing.
One of the things that we've noticed in the work of, I think, Professor Leonard, who's coming to give evidence next week, is that, yes, he looks at the genetic connection between the samples in the patients and the samples in the environment. And we've just discussed your views on what to do when there isn't one, as it were, or close one. What about when you have a group of patients who are closely located in space, in the same ward? Some of them are using the same shower or the same sink. They're in the same room sequentially, and they all have the same bacteria identified species-wise in their blood samples. But there's no close genetic connection between those individual samples. I think he would say that excludes a connection between the patients and therefore a connection with the environmental source. How would you respond to that?
I think it depends on the input to the whole genome sequencing. So I think, first of all, you would need to think about your sampling strategy at the time. And in the case of our incident, whilst we started sampling in Ward 2A and all the outlets there, we then had to divert resource to another part of the hospital. So we weren't focused exclusively on sampling Ward 2A over a prolonged period of time.
Because the patients were decanted, so you had to...
Well, we had to, because of the risk in Ward 2A, we had to start testing elsewhere to find somewhere to move the patients to.
Right.
That's when we found that the neighbouring ward had positive results. That's when we suspected it was systemic. And that's when we had to go and test all the wards. So we moved all the resource for the water testing of 2A, put on point of use filters and tested all those other areas. So the sampling strategy for 2A in comparison to if 2A had just been the only ward affected, was much more limited, if you see what I mean.
Yes.
And when it came to drains, which is particularly important for the Enterobacters, the drain sampling was extremely limited because there was a risk to patients just from the process of sampling a drain. The drains were in such a dreadful state with biofilm and reflux that actually putting a swab down that drain is bringing it back up into the sink, contaminating the surrounding environment and put patients at risk. So my approach to that was, I just need to know if we've got the same organisms in the drain as the patient to strengthen that hypothesis. And after that, I'm stopping because it's actually not safe to keep doing that. So the sampling strategies for different reasons were limited. So that input into that whole genome sequencing is far from optimal.
What would you have had to do in terms of a sampling strategy to produce enough material, genetic material, to run this whole genome sequencing testing program in such a way to enable you to exclude an environmental link?
So there's two things that could have been done. So Suzanne Lee talks about colony picks. So say, for example, you have a patient with Pseudomonas in their sputum, they're coughing up sputum, and you culture it in the lab. You look at the plates, there's all the colonies on the plates. If you are to pick off more than one colony, you will find different strains of Pseudomonas. If they're in patients like cystic fibrosis patients who have biofilm in their lung. The approach to typing and whole genome sequencing is just to pick off a single colony rather than 20 or 30 colonies, which was the view of Suzanne Lee. And there's quite a nice study in an intensive care unit where the researchers, instead of taking a single colony of Pseudomonas from a respiratory sample, they take 4, and they also sample the water at the same time. And by taking 4 colonies, they were more likely to get a match to the water samples. So the first thing you can do is you can increase your colony picks. Am I explaining this?
No, I mean, might it be the case, and I don't know whether there's any research on this, that there's actually a sweet spot where the number of colony picks you need to take generates an appreciable benefit in terms of likely to pick up a match?
I think so, and I'm talking to Suzanne Lee, her view, and I think she had some discussions with statisticians at the time, her view was 20 to 30. The other thing that you could do, but we can't do it now because the system's been dosed with chlorine dioxide, is if you wanted to, you could take sections of pipework. How much pipework you would need, I don't know, but you can do something, a much more sophisticated thing called metagenomics, which looks at the community of bacteria as a whole. It's even more sophisticated than whole genome sequencing. But the problem now is that there's been chlorine dioxide through the system, and that's going to have altered the biofilm. So there might not be any guarantee that you would pick up the same strains as the patient. So, and it would be quite a significant undertaking to, chop out bits of pipework.
Right, that's helpful. I've saved us some work for tomorrow afternoon, I think. Let's return to 2017. And am I right in understanding that it's in June 2017 that you go on sick leave because you got diagnosed with lymphoma?
That's correct.
And you don't return until January 2018?
Yes.
And before we leave this period of time, I wanted just to ask you to, using what you know now, to reflect back to the summer of 2017 and answer, giving your opinion, if you have one, of whether there was a link then between patient infections and the water system in Ward 2A.
I believe there was, yes. So prior to me going off sick, we were starting to see an increase in environmental organisms. We'd started to look at this. We did have concerns at the time about cleaning on the ward, but we had started to investigate what we felt was an increase in environmental gram-negatives. And we'd actually, I think it was under the instruction of Dr. Armstrong, we had arranged to set up a weekly meeting to discuss these infections. But unfortunately, I went off sick, and I don't know what happened at the time to that meeting. But I do believe around that time, yes.
What's the causal element within your hypothesis that there is a link? How is it the infection getting from the patient, water environment to the patients? And is there one reservoir or is there multiple reservoirs?
So there's multiple ways. There's what we would call direct transmission to the patient. So in the context of a hemato-oncology patient, that would be a patient showering in contaminated water with a Hickman line, which is a skin breach. That's the risk there. So there's the direct, but there's also indirect, and that might involve contaminated hands of a healthcare worker washing their hands in the water, transferring that to the patient. It might be related to equipment that has been contaminated. So around a sink, there's what we would call a splash zone. And generally speaking, if you have anything stored within a splash zone of 2 metres, then there's a risk that there will be splash onto that. So equipment can become contaminated and it can transfer to the patient that way. So that would be an indirect route. So those would be the routes. When we talk about drains, we then need to think about droplets and aerosolization, that sort of thing as well.
We'll come back to drain aerosization in a moment, but just at that point in 2017, were drains part of your theory of the environmental link?
No.
Do you think they were an issue then in 17?
I don't believe so. I think with the drains, I think the problem would have come to light eventually, but I think the problem came to light quickly because we applied point of use filters. And
can we come back to that when we get to that? Otherwise, we're going to get very confused very fast.
Sorry.
What I want to do is stay at 2017. So this artificial exercise of looking back from now to the summer of 2017. So you've identified that you think there was a link, and you've given us some possible routes. To what extent do you have a view about the sort of bacteria that were causing the infections? Were they all in one class, one species, or do they have a particular feature, the population that's causing the risk?
So at the time, obviously, the population was immunosuppressed patients in 2A.
No, I meant to the population of bacteria.
Oh, sorry, the bacteria. I'm trying to think back then. I remember that Stenotrophomonas featured back then, which is a waterborne organism.
But was it more than one type of organism that you were thinking
Yes, it was at that point, yes.
Right, okay. What we're going to do now is look to your period after your return, if you don't mind. Now, we have in your statement...
Mr. McIntosh, before we leave this, just to check with you that you have taken this as far as, or at least as I've understood, the distance you've taken this. Dr. Inkster has said that it is her view that in the summer of 2017, the experience of infection in Ward 2A was linked to the environment.
Yes.
Step one. Dr. Inkster has identified possible routes.
I think she identified 3.
Sorry?
She identified 3, my lord.
Well, I said possible routes. Which I've noted as direct showering, indirect contamination directly by a healthcare worker, and the, as it were, secondary contamination through contact with an item.
Yes.
Right. But my point is that I've got the opinion, I've got the possible routes. Is that all you wish to take from the witness?
Well, I think the only thing I wanted just to take the opportunity of clarifying is you've identified Stenotrophomonas as one particular possible organism. I'm not going to ask you to name all the possible organisms because I think it would be rather difficult. But what I'm trying to ask is, knowing what you know about was later found in the water and the biofilm in 18 and 19, are we able to say anything about the nature of the population of the biofilm that was in your eyes was causing the risk? Is it single species? Is it multiple species? Are you able to help us about your idea of what was going on then?
Multiple species.
So I think, well, I'm happy with that at this stage. I'm proposing to move on to your return and to deal with a matter of sort of the restructuring that was proposed upon your return. Now, you've covered that in paragraphs 490 to 503 of your statement. I'm not going to go to that on the screen. What instead I'm going to do is go to Bundle 14, Volume 2, Document 85, page 10, which reads, well, what is this? This is an email that you sent on the 24th of January 2018 and a reply from Rachel Green. But let's look at your email. What's this email about and why are you sending it?
I had come back to work the first week of January, and on the first day, I was informed by the head of service that things had been awful while I was off sick. There'd been difficulties with my colleagues,
Who was the head of service?
Professor Brian Jones,
Right.
and that he was changing the structure, and that I would no longer report to Tom Walsh and Jennifer Armstrong, but I would report to him, and then Professor Leonard, and then Tom Walsh, and then Jennifer Armstrong. So it was a change in the structure was proposed. And then he also said to me that I would need to give up my training programme director role, which was an additional role I had because I had a conflict of interest. The reasons for him saying this, they weren't explained to me. I didn't get an explanation as to really why the structure had to change, other than colleagues had been difficult while I'd been away and there'd been lots of issues that had come to light. Shortly after he had come into my office, there was a stream of colleagues that came to my office giving a slightly different picture, saying that there had been lots of issues, concerns about the built environment, that they were raising concerns, and that the infection control senior management team were not listening to their views. And they'd also informed me that they'd gone to a stage 1 whistleblow. So it was quite a confusing time for me because I had sort of 2 different stories, I guess. But I was very worried when I came back at the lack of progression of some of the issues that I had left. There had been changes to the infection control team. So when I took over as lead, I thought it was very important to get everyone working together as a team. And also I thought that the personal development of my ICD colleagues was important. I wanted them to be more autonomous because that was something we hadn't had. And I started to allocate them to sit on various different groups so they could, I suppose, gain expertise in a particular area. So I had people for water group, people for education, people for policy, that sort of thing. And I was trying to get more ICD input into the infection control team and promote closer working. When I came back, that appeared to have all been stripped back. And I was really concerned because there were lots of built environment issues. We were repeatedly told that the nurses in GGC did not do water, they did not do ventilation. And when I came back, it was evident that there was no medical leadership for those particular aspects. And I was concerned about that.
So you effectively decided that to resign at that point?
I supported my colleagues, and from what I had seen and heard, my major concern at that point was that the culture had reverted back to the culture around the time that myself and Dr. Peters were raising issues in 2015.
And on the next page, do we see more reasons that you've raised in addition to new structure in the team?
Yes.
You've raised an HI scribe issue. What's the Ward 4B2A issue?
Yeah, so Professor Jones said to me that he was changing the reporting structure and that I was to have no more input into wards 4B and 2A because he would be leading on those.
Right. And then the handover is you hadn't received one from...
I didn't receive one.
And then the TPD you've already mentioned.
Yeah.
So I take it that your resignation doesn't go ahead?
It doesn't, no.
Why is that?
I was asked to go and meet with Jennifer Armstrong, who had told me that she'd spoken to various people and essentially persuaded me to stay in the role, and the reporting structure was not changed at that time.
Had the reporting structure changed, what impact would it have had on the ability of the infection control team to spot unusual microorganisms?
I mean, I think we're dependent on microbiologists because our surveillance systems are not adequate to spot these unusual organisms. I'm not convinced a change in structure would change the ability of a microbiology colleague in identifying an unusual organism.
But I suppose one of the issues we've discussed with the witnesses is that when you gave evidence at the very beginning of your session about how the Glasgow team, to your eyes, was quite good at dealing with standardised reporting and things that were known, and was less good at dealing with things that were unusual. And I'm wondering whether this change, in addition to having the changes that you've discussed in this letter, would have any impact on the ability of the team to react to the unusual and the unexpected?
I don't believe changing the structure would help with that.
Or would the change of structure have harmed it in the way they proposed by inserting layers between you and the medical director?
Well, microbiologists would still be reporting unusual organisms, but I suppose when it came to me to do anything about it, I don't have access to either the infection control manager or the HAI executive lead without going through other people.
And that would have been 2 layers you would have had to go through.
2 layers. And similarly, if the HAI exec lead wanted to speak to me, it would be, coming back down through those layers as well.
And the HR executive lead is Dr. Armstrong. Yeah.
So I always think that it's really important that, essentially, I had a direct line to Jennifer Armstrong, even though it wasn't down on paper. I could phone her at any time about any issue. And I was really concerned about that, the ability to do that effectively being removed, particularly given all the issues that my colleagues had told me about when I came back.
And who do you think ultimately decided not to go ahead with this restructuring?
It's not clear to me. Possibly Dr. Armstrong, but that's not clear.
But it didn't happen in any of it?
It didn't happen.
Right. Now, whilst you were off on sick leave, we can take this off the screen, we've heard evidence about how 3 of your colleagues raised an SBAR on the 3rd of October 2017 and ultimately met with senior people in the health board, and an action plan was produced. I appreciate whilst you were on sick leave at the time, but just so we can clear it up, did you have any involvement in the creation of the SBAR, the meeting, or the creation of the action plan?
No, I did not.
Did you know about the creation of the SBAR before you returned?
Yes, I did.
And how had you heard about that?
Colleagues were coming to see me when I was off sick.
And telling you things?
Telling me things, but I was better at that point, and I kind of wanted to know what was happening at work, I guess. So
right.
I don't think we can be critical of them for doing that. It was, inevitable that there would be something said about work.
What I'd like to do is to look at an email sent on the 12th of March from you to Professor Jones, Mr. Best, that's the Bundle 14, Volume 2, Document 89, page 100. Now, what this appears to be, what's going on here, because it looks like you're attaching something to, you see how it's called response to microbiologists?
Yes.
Are these the 3 microbiologists who raised the SBAR?
Yes.
Right. So what is it that was attached to this email?
So when I came back, I got sent a copy of the SBAR, and I wasn't happy with the content.
Of the SBAR?
Yes. So I made some amendments to the SBAR, and I was also concerned because this document was being tabled at the Acute Infection Control Committee. And
was this the action plan?
Yes.
Right.
And there were, my colleagues hadn't received it.
So let's look at the action plan and the papers of the committee. I think it's Bundle 20, Document 48, page 794. So if we were to look at the previous 2 pages, so 792, we see this is a paper for the Clinical Care and Governance Committee.
Yes.
Now, this has happened well after the events we're discussing.
Yes.
But the action plan that we see attached at 794, is this anything you've had input into?
Not this version, no.
So what version did you have an input into?
Well, I got this version, but I changed it and I sent them.
And that's the email Dr. Armstrong we just looked at?
Yes.
So in March, you received this version?
Yes.
And you commented on it?
Yes.
Did they take on board your suggestions?
So at the time, they appeared to, and I think it went to another committee. I think my version went to the AICC, but later, I think into 2018, 2019, they reverted back to the previous version when issuing the update, and I expressed concern that we weren't using my updated version, and I was told for governance reasons, I believe, that they had to stick to the original one, even though it wasn't accurate.
Yes, because one thing I don't really understand about this action plan is it's an action plan to do things that the people who've inspired it think is about infection prevention
Yes.
control. Who's in charge of implementing this action plan?
That was never made clear to me. My feeling was it was Dr. Armstrong, because it was a step 1 whistleblower and she chaired that and instructed that action plan.
Why wouldn't it be you as lead ICD?
I didn't have any role or responsibility, I guess, in a whistleblowing process, and many of these actions are not just for me as an ICD. Many of these actions involve the states and other departments, so I don't have any sort of control or remit of allocation of resource or, to states. I've got no managerial responsibility or anything like that to the other people that might need to be involved with this. So I
From
think
your
it
point
should
of view,
be
the ownership of this in terms of implementing it should sit with the person who chaired the whistleblowing meeting.
someone very high up in the organisation. Yeah.
But although you have direct access to Dr. Armstrong at this point, you're not very high up in the organisation. Would you?
No, not at the level of a lead ICD. No.
Right. What in your eyes was missing from the action plan? If you want to look at your statement, page 157 has some of the items.
Yes. So I was particularly concerned about aspergillus. It wasn't open and transparent in relation to those 2 IMTs in 2016 and 2017 that I had chaired. I think there was reference to rates being comparable with York Hill, but we had in fact found significant issues with the environment. We were concerned about the rooms, the chill beams, the water leaks, so I felt that was not an open and transparent update on aspergillus. It felt to me that information wasn't being shared with these ICDs. There was a suggestion that they were unaware of, plans for all the upgrades to the negative pressure rooms and the BMTs, and that information was available, and it was available from people around the table. It wasn't just information that I held. So I think the comment was lead ICD is dealing with this, which I found to be insufficient, because they could have given them much more information and perhaps more reassurance at the time that things were being done, albeit slowly.
Because the thing that I'm finding a little strange about this action plan seems a very important document from an outsider's point of view. If we go back to it in Bundle 20, it lists a series of issues, a current position, and actions. Now, one might argue about whether the current positions column is accurate, and one might argue whether the future actions ever happened, but it is an action plan.
Yes.
And the odd thing about it is the list of items is a subset of what's in the S-bar.
Yes.
Why isn't it the list of items, a list of items that Dr. Armstrong or anybody else who was at the meeting in terms of management thinks need doing? Why are they only acting on the things in the S-bar? Because you have, at this point, which is early 18, we've had a whistleblower. You've had a number of problems with Ward 4B and its upgrades. If you're going to nod, you're going to have to say yes.
Sorry, yes.
You've had a number of problems with Ward 2A, yes?
Yes.
You haven't yet got into the Ward 5C, 5D thing.
Yes.
And you've learnt about you're about to learn about the general ventilation.
Yes.
Is it fair to say this action plan is a reaction to what's in the S-bar? It's not a list of actions designed to solve all the outstanding problems of the hospital?
Yes, I would agree with that.
Are you aware of whether there was a single list at this point of actions to solve all the outstanding problems of the hospital?
No, I'm not.
Would you expect to have been told about them if they had infection prevention control relevance?
I would have, yes.
So anyway, you make comments, they don't get incorporated, It can incorporate to AICC, but not at this higher level board meeting?
Yes.
Right, okay. To what extent were you involved at any level with providing information to Dr. Armstrong on the implementation of these items?
There were regular updates at meetings, so AICC, but she wasn't at that, but she would get the minutes, but also Board Infection Control Committee, there were updates.
On the action
That
plan?
as well, on aspects of the action plan. I don't think there was ever a day where we went through the entire action plan, but aspects of it were updated.
And was ever at any point items that the three microbiologists didn't know about, but you were concerned about, added to the action plan?
No.
Now, I'd like to look at a document you might not have seen at the time, but you're mentioned in it, if only in passing, which is the Stage 2 whistleblower report provided for Dr. Redding and her colleagues, or Dr. Redding particularly.
Yes.
Bundle 27, Volume 4, Document 6. And that's page 81. Now, if we can do the whole page, it might be easier. Thank you. So this is a report which Dr. Redding did not see at the time, but it's Dr. de Keestekker's report, I'm assuming, going upwards within the organisation. And do you see how, I mean, you got the Stage 3 report later on, I understand.
Yes, I did.
Why would you have got that?
I don't know. I queried at the time why that was sent to me. I was not part of the whistleblowing process. I was not interviewed by the individuals conducting the process. I don't know why I received it.
Are you a whistleblower?
I whistleblew, but externally to the organisation.
Yeah, exactly. So if we go on to page 82, we see a list of the people Dr. Keestekker has interviewed, and we see that you're mentioned, along with the other members of the infection prevention control team, sort of the senior trio. There's Mr. Walsh and Sandra Devine, and Dr. Jones is your head of service, and Dr. Kennedy. Do you know why he's been interviewed?
No, I don't.
No. And Dr. Rachel Green, what involvement would she have with the three whistleblowers? Would she be their head of department, effectively?
She was the chief of medicine for diagnostics, so she would sit above the clinical director level, so sort of 3 up from consultant microbiologists.
Now, if we look on the next page, top page 83, we have a paragraph. Now, these, of course, are Dr. Keestekker's words, and I will ask her about them next week, but when she says, I discussed with the lead infection control doctor, we can probably zoom in at the top half of the page, the 3+ versus 6 air changes issue. I'm assuming she'd be talking about you at this time.
Yes.
So did she discuss with you the 3 versus 6 air changes issue?
I believe she did, yes.
Some people say they believe she did, but they don't remember. Do you remember her discussing it with you?
I remember talking about all the ventilation issues at the time and the various SBARs that I'd written, and I gave her an update on them, so I'm fairly confident, but I can't say for sure.
The Scottish Hospital Building Note recommends 6 air changes. I think that's a reference to SHTM 0301.
It is, yes.
Right. Now, the next sentence is interesting. If we look at it in 2 parts, we'll pass over the first 4 words, however, the infection control team for a moment, we'll come back to that, and then considers that the additional risk to patients in standard accommodation is negligible, as 3 air changes brings down contamination to 5%, and it's single accommodation. Is that something that you would have said, Dr. Keestekker?
Highly unlikely to be language that I would use. I would have referred to the CDC, the Centre for Disease Control table on dilution of airborne contaminants. I wouldn't use that sort of language.
It's a hard question to ask in the middle of a morning of evidence. Does the CDC table say 5%, or would it explain it a different way?
It says that 6 air changes per hour in terms of the time that you need to leave after an AGP would be anywhere between around 45 and 60 something minutes.
So an EGP?
Aerosol generating procedure,
yes.
For 6. So then if you drop that to 3, then you effectively double that time. So that's where I got the 2 hours from. So if you had 6 air changes, you would wait approximately an hour. If you had 3 air changes, you would wait 2 hours.
So you would measure this in time, not in percentages?
And at the same time as this document was produced, there was a board infection control committee meeting where I was asked to explain this to Dr. Armstrong, and I quote the Centre for Disease Control guidance at that meeting. And I was then tasked by Dr. Armstrong to look at it again with Dr. Kennedy's input. It seemed quite straightforward to me because I had the CDC guidance, but nevertheless, we did look at it again and we reported back at the next meeting. So it felt to me that perhaps my view was being challenged on this air change issue.
And then if we look at the next sentence, there has been no transmission of high-risk pathogens and now alternative pathways in place for the very high-risk ones, such as MERS and MDR-TB. And then the final two sentences, are those bits a reference to your SBAR and the SOP changes involved?
Yes.
And are they broadly accurate?
Well, they're not the full range of recommendations, they're...
But within each one?
Uh-huh.
And what I want to just ask is, ignoring again for who is saying this, is the second half of this, is this paragraph broadly accurate?
The first paragraph?
The whole of this first paragraph, is it broadly accurate?
Well, in terms of transmission of higher risk pathogens, it would be too early to determine whether there had been an outbreak of tuberculosis, for example, simply because in many individuals the organism becomes latent and while still inhale it, it will sit in the lungs for a period of time and it will reactivate in the future. And it might only be at the point where you get the reactivation that you send the sample to the reference lab and they type it and they match it to, another patient who'd been in that same ward or a staff member who'd worked on that ward. So it would be too early, in my view, to say there's been no transmission of higher risk pathogens, particularly respect
since the hospital opened.
To TB. Yeah, we couldn't conclude that at that stage.
So would you say that?
Unlikely to have said that.
So we go back now, as I said we would, to the third sentence. However, the infection control team considers. I'll often ask Dr. Teresa why she didn't say the lead infection control doctor at this point. But do you take anything from the change of phraseology to mean that the actual source of this is somebody else?
Yes, because she talks about the lead infection control doctor at the beginning. So I guess why not just continue on that theme? Why change to say infection control team? That seems odd.
So who else in the infection control team could explain this to her?
Sorry, could we just go back to the list of attendees?
Yes, of course. Previous page, please.
So Sandra Devine, in her role as Associate Nurse Director for Infection Control, I think would be the only one. Brian Jones may have been asked for review as a microbiologist.
So they're the possible two sources of that information?
Yes.
Thank you. Now, if you go back on page 83, this paragraph, this is being done about a year after Mr. Parry's email to you.
Yes.
Am I right? Would you agree with me that there's no evidence in this document that Dr. Kasek has been briefed about the justification for the ventilation derogation?
Agree.
Now, I need to go to the bottom of this page where there's a list of criticisms of Dr. Peters. And how would you respond to these criticisms of Dr. Peters as someone who works with her?
I wouldn't agree that she finds it difficult to accept balance of risk for the reasons I explained earlier. In terms of undertaking risk assessments, you need to be fully informed, and there were many situations where we didn't have that information.
Is there anything in there which you you find has any sort of basis in your experience?
No.
One of the issues, the last thing is a discussion of sending emails.
Yes,
Did any issue arise with Dr. Peters and the way she sent emails that you might have addressed with her?
it did. Yes.
If we take that off the screen, you can tell us what that was.
So when I came back in 2018, initially I was on a phased return, so I was only in 2018.
18, yes.
Phased return, so only in part of the week, which meant that I was not attending many of the morning handover meetings or departmental meetings where I would normally be communicating issues. I was dealing with the water IMT, and I would come back to my office quite late with a long list of tasks, and communication to microbiology was quite far down the list because I had lots of other people to communicate with, including government and various other individuals. And I was often sending updates late in the evening, and microbiologists were getting phone calls at home and I hadn't sent them an update. So there was definitely an issue with my communication, except that it wasn't timely to them at the time. So in addition, when I did send updates, I would get a lot of feedback from Dr. Peters in sort of red writing for each point, asking for more information. And at the time, that was adding to my workload. But we spoke about it, we met and spoke about it, and I accept that my communication to microbiologists was suboptimal. It was exacerbated by me having communicated to an individual ahead of a weekend. They said I hadn't, but actually I had, so that had sort of fueled things a bit more. And I think also what came out of that conversation was a lack of trust. So I think colleagues found it hard to understand the fact that I came back to work. I supported them, I attempted to resign, and then I went back to work with essentially the individuals that they'd raised concerns with. So we had a long conversation about all of that, and we cleared the air and moved on.
And did Dr. Peters' email style change?
It did.
Now, I'd like to pick up an issue that relates to the provision of water testing results to microbiologists, which I think comes up in a water safety group meeting on the 16th of October 2017. So that's bundle 11, document 25, page 77. And I think it's actually on page, well, it can be a number of different places. So your statement suggests this is the place to go, and I'm a little bit thrown by what I find, and I wonder if you can help me out. So firstly, let's check you were present at, your record's being apologising at this meeting for not being there. It's the first thing that threw me slightly.
I wasn't there, yeah.
Right, and then we have on page 77, item 5, and over the page, there's a discussion sorry, I'm just going to make sure I've got in the right place. Yes. Do you see how it begins? IP noted of the issue with infection control doctors regarding sampling for Legionella?
Yes.
Now, there's that entry, and then there's another entry on page 79, which is IP note Ward 7B. IP noted of the issue within Ward 7B within the showers. Infection Control College looking to obtain historic records. Are these the things you're pointing to?
Yes.
Right. Let's go back to the first one on page 78. How was it that infection control doctors were trying to obtain sampling for Legionella, and how does this relate to the conversation we had before lunch about meetings with Mr. Parry around water testing results in 2016?
I understand that when I was off in 2017 that infection control doctors had difficulty obtaining results that they were asking for.
Now, were these infection control doctors who had a couple of infection control sessions in their microbiology,
Yes.
but it's not microbiologists with no infection control role at all?
I don't believe so, no.
No, okay. And what do you understand from the various documents that you saw when you came back was the consequences of them asking for this material? Did they get it?
I don't believe so, no.
Why do you think they didn't get it?
I don't know.
I mean, does this minute help us understand why they didn't get it?
No, I think part of the problem, which I alluded to earlier, was that when I was off sick, the service was stripped back and there was no infection control doctor input at either this board water safety group or also the local sector group. Had there been, there might have been that exchange of information.
So we go back to page 77 and look at the membership of the group. Now, firstly, previously there's been, you were recorded as attending some of these,
Yes,
and indeed Professor Williams has attended meetings.
yes,
And you're recorded as giving your apologies at this point, but at this point
Yes.
you're off sick.
yes,
So it must be a standing apology.
yes.
And no one's asked to replace you.
No.
No. Wasn't Mr. Walsh set down as the co-chair of this committee?
Yes, I believe so.
Did he attend?
Not frequently, no.
Did he ever give you an explanation of why he didn't attend the water safety groups that he was co-chair of?
No, I think he delegated a lot of responsibility for that onto Pamela Genidis in particular.
Well, we've heard from her about the delegation, so
Yes.
I'll probably leave it at that. Right. What I want to do is to take that off the screen and move on to the start of the water incident. Now, if we look at the, I'm not going to go to paragraph 559 of your statement where you describe this. I'm going to look at some INT bundles instead and try and do it that way. Bundle 14, emails first. Bundle 14, volume 2, document 88, page 75. Is this in effect, this email from you on the 1st of March, when the Beast from the East had been around, is this effectively the first IMT minute of the water incident?
Effectively, yes, I had to do things by phone.
Right. Now, what's the connection in your mind between the water incident and the previous 2016 aseptic pharmacy Croupier-Viardis cases?
So at this point, I'm suspecting a link, initially either through the aseptic pharmacy being the source because patients in Ward 2A would receive products from that unit, chemotherapy, nutrition, that kind of thing. But I'm also concerned that we have this organism in a high-risk unit and the potential for patient infections as a result.
But you're not currently looking at anything more than a point source of infection, in a sense?
Not at this point, no.
No. If we go on to the teleconference on the 17th of March, so that's bundle 14, volume 2, page 107. So this isn't an IMT. What's this meeting?
This was a teleconference that was set up. I think it was Dr. Armstrong that requested it because she wanted early expert input into what was quite an unusual situation at the time with this unusual organism, Croupier-Viardis. And we were particularly keen to get input from Health Protection Scotland colleagues, Health Facilities Scotland, but also Public Health England.
And how is this teleconference related to the IMT, the team itself, not the meetings?
It was separate from the IMT. I think this was on a weekend.
So is this more of a briefing or something, or is the decisions being made?
I think it was really an opportunity to seek expertise
Right.
independently from the IMT process. I think, people took the situation very seriously and there was, definitely an appetite to have a lot of experts around the table early on and discuss what might be happening here.
And at this point, was there already a decision to install point of use filters?
I would need to check the minutes. They weren't placed immediately.
So I'm just going to find the page reference for you. So if we go on to the next page, at the bottom, do we see the short-term control measures continue as planned with the installation of point of use filters?
Yes.
Right. Now, the reason I went to that is because of the next entry. So this is 17th of March. Consider tap cleaning. Now, at this point, is anyone referencing back to the decisions made back in 2014 about the Horn Optimum taps and the cleaning of them?
I believe I was starting to ask questions about the decisions at that time, and that's when Sandra Devine sent me the minutes. But I don't recall any other conversations.
But the estates people who were at that meeting aren't coming to you and saying, you know what, we should probably have a plan.
No.
At this point, well, you explain in your statement at paragraph 556 that at this point you then start to come across Stenotrophomonas maltophia and Pseudomonas fluorescens, if I pronounce that correctly,
Yes.
which I probably haven't. So why is that is that different from back in 2016? Is that an unusual development to see those bacteria?
At the same time as having an organism like Cupreavadis, that was strengthening the hypothesis that it was the water system. There may be different sources of Stenotrophomonas. It's not always hospital water. It might be contaminated solution or a piece of equipment. There might be other reasons for the Stenotrophomonas, but when you see it with the Cupreavadis, that to me was strengthening the hypothesis that the water was the source.
And at this point in March 2018, are you getting the water testing results now?
I was, yes.
Now, again, slightly jumping forward, in April, you set up the water technical group.
Yes.
Now, have I got it right that the water technical group is set up at a point when the water incident has sort of reached a sort of partial conclusion in some sense?
There were some meetings before, I would need to check the dates, that had a different name called a water review group.
Right.
So there were some people meeting, I think, before the official water technical group, but I would need to check those dates. But essentially, yes.
And these two groups, what relationship do they have to the IMT?
So there were some of us who were represented on both. So I attended the water technical group, as did Annette Rankin and Ian Kennedy.
But you didn't chair the water technical group?
No.
And who was the point of reporting contact between the water technical group and the IMT?
It would generally be me, but if I wasn't at an IMT, one of the others might do that.
Because Dr. Deegan, in his later review of these issues in 2021, takes the view that that was somewhat of a flaw of governance and you should have had a separate person reporting into the IMT. Do you have any comment on that?
I suppose ideally the chair of the water technical group might have been the person to then come and report into the IMT.
And that's Mary Ann Kane.
Mary Ann Kane, yes.
But she didn't attend the IMT.
Not frequently.
I'm assuming she's relatively busy, because what role did she hold at that point?
At that point, she was the interim director of facilities, yes.
Yes. What I want to do is look at a water technical group minute on the 13th of April 2018, which is bundle 10, page 9. Now, you're not actually present, but an awful lot of people are, including Mr. Gallagher, Dr. Kennedy, Mr. Purdon, Mr. Parry. And if we go on to page 10, we see it was noted in the middle, at the bottom there, it was noted that every floor had positive and negative readings, whereby this would indicate widespread water infection. And then at the foot of the page is talk of decontaminating the system. and there's a reference to widespread contamination of the buildings in the next minute on the 20th of April, which is page 14. And you're present this time by telephone. Now, what I want to just make sure is at this point in April 2018, is there anybody disagreeing with the idea that there's widespread contamination of the water system?
No.
When you report it to that higher level briefing or to Dr. Armstrong, is anyone saying, no, you're wrong, the water's not contaminated?
No, no one.
Would there have been any evidential reason to think the water was not contaminated?
No, definitely not.
Why did you think the water was contaminated?
At the time, we were working on various hypotheses, and the nature of the bacteria to me were those found in water and soil, and I thought there had been some sort of ingress at some point in the system. At the time, I was thinking about uncapped pipes.
During the building process?
Yes.
That was your main theory?
At that time, yes.
Now, how would you characterize the way your actions were being received by the medical director, the directors of estates, senior people in the health board at this point?
I would say throughout this incident, people were very supportive. People went above and beyond to implement these measures. There was no one disagreeing at any point in time that we had an issue with widespread contamination. There was a lot of good team working. There were some issues with the IMT around communication and operational issues, but overall, it was very supportive at the time and no challenge.
Was there eventually a debrief meeting for the IMT?
For the first part of the IMT, yes.
And that would have been on the 15th of May?
Yes.
Who chaired it?
Laura Emery chaired it.
Now, I'm not going to take you to the minute because we won't get through everything we need to get through, but I'm going to take you to a document we think might be connected to it. And I want to see if you can recognise it, which is it's in two places, but the place we can go into is Bundle 27, Volume 5, Document 19, page 46. It's also in, just for completeness, Bundle 8, Document 6, page 53. But do you recognise this document?
I do, yes.
Who created it?
I did.
Right. And just at the bottom of the page, we see it describes the type of incident, causative organism, environmental gram-negative and fungi from biofilm, main presenting illness, bacteremia, and then it says food, which surprises everyone I've shown it to them. Go over the page. What should we take the highlighting to mean?
That is the source. This was a template, a standard template.
Where do you get the template from?
The National Infection Control Manual at the time.
So when you completed this document, to whom did you send it?
I sent it to all members that had attended the IMT and the debrief.
And did anyone come back to you and say, no, you've got it wrong?
Nobody, no.
Now, is this around about the right time for you to have created the list of organisms that should be tested for with Mr. Parry?
Yes.
You think there's around about now?
And the water technical group had definitely been established, so around about that time, yes.
Now, we don't have a copy of the first version you created, but in order to connect it to the story, I want to show you what might be the current version, which is Bundle 27, Volume 1, Document 19, page 278, which is 276, which is the Water Safety Plan version J, that we understand there's another one about to be created. If we go to page 394, we have the procedures in event of out of specification samples. Whilst this isn't your document, but it's many years later, if we go on to the next page, and the next page, and a list of permissible results, on the next page, again, the sampling frequency, and the next page, more sampling frequency. The next page, again, more sampling frequency, and page 400, more sampling. Is this the sort of thing you were creating back in 2018?
It's much more comprehensive than what we were creating. What we were creating at the time was with a view to when it would be safe to remove point of use filters. So the first part, where you've listed the organisms and the parameters,
That's page
Would it be
394.
based on myself and Ian Powrie's work, but the second bit with all the different wards and frequency of testing is not mine.
So someone's made a more comprehensive version.
Yeah.
Now, I get the impression from reading the material of Dr. Deegan and his review that you had an issue at this point about executive control of the response to the water incident.
Yes.
I'm not sure I fully understand it from his review. Can you explain what your concern was?
So around, I think May time, I was concerned because we had the IMT, we also had the water technical group, and then we had a group that I didn't really have any link to the operational group. And I felt because of the complexity of it all that normally an IMT is an independent, committee. But due to the complexity, I felt that there needed to be director level oversight because, as I said before, I can't direct resource as an IMT chair and get things to happen. And I was concerned that things were slowing down. My view at that time was we knew what to do. We'd had lots of discussion about chlorine dioxide installation, but people wanted to wait for reports. And I just felt things were being slowed down. And
When you say people, who do you mean by people?
Senior people in the board, medical director, directors, director of facilities.
So effectively they're wanting to get reports to check that your proposal is roughly right.
Yes. But from my perspective, I felt that the problem was very obvious. We had widespread contamination and that we would need to employ a biocide. I'm not an expert in choice or delivery of biocide, but I felt at a very early stage we could have made contact with experts to start to get that moving, rather than wait for reports. So that was one of my concerns. I was also concerned at the time, having these three different groups, the IMT, the communications to senior members of staff were coming from all sorts of different angles. So people would come to IMTs with laptops and they would sit and type and press send before the end of the IMT, before myself or Sandra Devine got a chance to brief the medical director, the HA exec lead.
Who do you think is taking notes then?
There were individuals in the IMT taking notes and sending them up to their directors.
But you said you wanted director level supervision. I don't understand why.
Yes,
that's the problem.
I wanted sort of more control over the communications, a proper communications channel.
So you wanted to report to a director level group?
Yes, I wanted director level oversight with then reporting further up. So the intention was that the director of women's and children's would chair the executive control group, and that would then report up to the chief operating officer and the HA exec lead, and it would all just be pulled together into a governance structure.
And that would have got rid of the operational group, whatever that did?
It wouldn't have got rid of it, it would still existed, but we would have had visibility of it and also oversight of it.
But in a sense, there was oversight of you because the medical director and all the other senior managers were making decisions in reaction to what you were doing. Surely that's effectively the same.
They weren't always coming to the IMT though, or they were coming via different routes.
Such as?
So they would come via general manager of women's and children's or the director, and they might give me feedback from a meeting that had taken place and a decision about the IMT or something for the IMT to consider.
Am I right in thinking that the position is effectively you wanted to be managed by a group but in a predictable way?
Yes.
Right. Now, what I want to do now is to turn to the state of the drains in Ward 2A. So again, staying with our time, we're in May, so we haven't got to decant yet. Can we go to, well, we don't need to go to them necessarily. There was a series of Stenotrophomonas and Enterobacter PAGs in May 2018. Do you remember those?
I do.
And then there's the discussion of the drains. What was the concern that you had about the drains at this point?
At the time of these incidents, nursing staff were reporting to us that they were describing it as black muck, refluxing from the drains back into the sink.
And is this related to the point I stopped you earlier on about related to the installation of point of use filters?
It is, yes.
So how can you explain the connection between these two things?
So the drains were always going to be a problem because of what we subsequently found in relation to the structure, but by attaching a point of use filter, we were reducing the distance between the tap and the drain, And by doing so, we were encouraging more splashing. And when you have splashing, you're more likely to dislodge the biofilm and bring it back up into the sink. So I think the problem was always there. It would always be discovered, but it was, I suppose, brought forward by the application of point-of-use filters.
Would a point-of-use filter also affect the volume and speed of water leaving the tap?
It could do, yes.
And how would that affect the biofilm in this drains?
Well, anything in terms of volume or speed that generates more splashing will dislodge the biofilm.
Before the point-of-use filters were fitted, would the speed and volume of water coming out of the tap help to clear the biofilm?
In the situation,
Or am I not understanding it?
in the situation, well, ordinarily, yes, but the situation that we had structural abnormalities in the drains. They were not normal drains, if you like. There was not free flowing of material.
So is this because the drains went horizontally backward from the sink?
No, that's actually a recommended design. It was because when we looked at the back of the sink and where it joins the pipework, there was a lip which was promoting pooling and stagnation of water. And when you get pooling and stagnation, you will get bacteria and biofilm forming. Further back in the drain, however, there was corrosion of an aluminium spigot. And around that, at the time I was told it was sealant and it looked like sealant. It was white material that was causing an obstruction in the drain. And when you've got obstruction and stagnation, well, that's the perfect conditions for biofilm. On top of practice that was going on in the sink, decanting, disposing fluids, other products down, providing nutrition. So you had the perfect storm in that drainage system.
Right. And so why, well, this is before the chlorine dioxide system is fitted.
Yes,
And I get the impression that drains remains a theme after it's fitted.
yes.
Why did the chlorine dioxide system that is to come not ultimately address the problem of the biofilm in the drains?
It wasn't established at the time, the chlorine dioxide. It took a long time to install, and once you install chlorine dioxide, it doesn't work immediately. It needs to actually build up in the system, and you need to get to the point from the central dosing to the outlet. You need to reach an adequate concentration at the outlet, and that can take an awful long time.
How
to
long are we
achieve-
talking? Weeks, months?
No, I mean, it could be even up to a year because it's got very extensive, well, in my view, biofilm to penetrate through before it gets to the outlet. So it can take a long time for those concentrations at the outlet to be adequate.
And so, am I right in thinking that eventually the amount of chlorine dioxide would be strong enough to clear
Yes.
the biofilm?
Well, it's not going
Or is
to
that too
clear
simplistic?
the biofilm because it's such a complex, community of bacteria, and they're well protected in what we call a matrix. It's very difficult for chlorine dioxide to penetrate the biofilm. It might slough off the upper layers, but it's never, in my view, going to completely clear that biofilm that was well established.
We're going to come back to biofilm and the drains, I suspect, again. At this point, did you have any awareness this summer of 2018? What was your awareness of the diversity of the microorganisms involved?
There was diversity. We were seeing bacteria that I had never seen before and was having to look up.
And in terms of numbers of different genuses being represented, are we talking fingers of one hand or more than that?
More than that.
Right. Now, I'd like to look at something in your statement on page 182. This is, I can't pronounce this bacteria. Could you help me, please?
Acinetobacter baumannii.
So this Acinetobacter incident, you've discussed it here in your statement, and you've referred to it as highly linked to ventilation.
Yes.
So I suppose what I'm trying to do is to do a bit like we did for the Elizabeth King here, trying to work out what you think are the hypotheses of the different routes. And so what are you thinking is the mechanism by which this bacteria has been linked to the ventilation?
So Acinetobacter, whilst it's waterborne, it's a bit different from the other organisms we've spoken about because it also likes very dry and dusty conditions and it will survive well in them. And it is the airborne dispersal of Acinetobacter is described. Once it gets into an intensive care setting where you've got very sick patients, lots of devices, lots of equipment, it's very difficult to get rid of it. It's very hardy in the environment, very challenging. So when you see Acinetobacter, the things that you're thinking of usually could be water, but also cleaning issues and dust. And then ventilation. That came a bit later for me. We'd sort of worked through the process of investigating this, trying to find out where it was coming from. There were issues with the sinks in this unit. They had trough sinks, and these are the sinks that you would undertake a scrub, surgical scrub. They had them in the corridor next to equipment, so there might be splashing. So we were concerned. There were a few things we were concerned about. The cleaning as well. We'd been raising issues about cleaning and high-level dust. So initially there were other reasons for it, but later into 2019, I became aware of the verification report for the paediatric ICU, and the ventilation was suboptimal. And at that point, I wondered whether the Acinetobacter issue was in fact related to ventilation.
So when you say the ventilation was suboptimal, in what way would it have been suboptimal?
The pressure, so the specification for a general ITU is similar in a sense to the neutropenic ward with the absence of HEPA filtration. So it's 10 air changes per hour and 10 pascals of positive pressure. The ITU hadn't been designed that way. They didn't have sufficient isolation rooms. So I can't remember the exact details, but the air changes and pressures were not adequate.
So why would you see the lack? Well, would the air changes not have just been 3 like the rest of the hospital?
No, not in a critical care unit. They're close to 10.
Do you have any reason to think they weren't 3?
No.
But if the air change rate or the pressure differential is less than the guidance, how's that affecting the possibility that the Acinetobacter are persisting in the environment? Is that how it's happening, or?
Because for Acinetobacter, it's known that you can get airborne dispersal of Acinetobacter. So when that happens, having adequate ventilation parameters would be mitigation against that.
So is that by dilution, by air change?
Yes.
So what role would pressure differential play in mitigation?
So pressure differential is about if your pressure's high, your positive pressure's high, then that's stopping anything getting in.
So basically, you'll be able to keep it out of rooms.
Yeah.
Right. So in terms of the individual rooms that the patients are in, a positive pressure in the rooms would help.
Yes.
But in terms of a more open plan unit, this is an open plan unit to some extent, isn't it?
No, there was a mixture of isolation rooms. So there was a mixture of PPVL rooms, later a negative pressure room, and there was a mixture of what we would call a bay with maybe 6 to 8 cots or 4 to 6 cots.
But in the bay, positive pressure wouldn't help. It would have to be the air change that does the work.
Yes.
So what I'm trying to get to is, are you saying that the air change rate is relevant to this ventilation linkage that you see here?
Yes.
And that's something you wouldn't have thought of in 2018. It's something you've come across later.
It was something I came across later, yeah.
Now, there was an earlier cluster. I called it a cluster. You may not call it. So that's me just because events happen at the same time. I'm sure that's wrong. But bundle 2, page 58. So this is events in the second half of 17. Would you have been aware of this when you returned from sick leave?
No.
Were you aware of these PAGs when you were dealing with the May 2018 incident?
Yes.
Right. Are they part of the same story in your mind or separate?
They're separate.
Why are they separate?
Different strains. So the IMT that I chair, I talk about a previous strain. I'm talking about a previous strain in the paediatric ITU unit.
Right.
So there were cases, we had a line listing, and there were cases with a particular strain 5, I think it was, that were attributable to the PICU at that time in 2017. I don't know if there was ever a PAG or an IMT, but they were previous cases in PICU, which is what you would expect for this organism because it persists.
Well, there was a PAG because we're looking at its.
That's neonatal unit, I believe, that one.
Sorry. The next one is. No, you're absolutely right. The next page, just for completeness, then page 60. We should look at it. Page 60, please. So that's a different ward as well. Which ward is that?
That's 3A. I can't actually remember what's in 3A. I think maybe a general ward or surgical.
The point I'm trying to raise is albeit the patients are different, if you're suspicious of an environmental ventilation link in the May PICU case that's described in your statement, what sort of questions will we be asking ourselves about these two PAGs the previous year in different parts of the Children's Hospital of a similar but albeit different strain of Acinetobacter?
Could be ventilation related, but equally it could be water, or it could be reflective of issues with cleaning and dust in the unit. So
the question that I want to understand, and this may be the wrong example to do it, so is that quite often one sees, particularly the year you're not there, PAGs for bacteria species that we've learned to recognise as unusual, because people tell us they're
Yes.
unusual, that attract a PAG, but no IMT follows. Whereas you seem to get the impression that when you are around, it's the water incident, and therefore things are being rolled up into the big IMT.
yes.
Is there any element of reluctance is the wrong word, and non-upgrading of PAGs to IMT happening when you're not there that you've noticed?
I know that when I came back, there was a view that the triggers that I had set for action were too sensitive, and that too many PAGs were being held. So I think there was a view that, yeah, I was reacting to things too often. But my assessment of that is there were issues with the building, and I felt that the triggers were indeed picking those things up.
So who thought the triggers were too sensitive?
I believe it was the associate nurse director at the time who sent
Vine.
emails. Yes.
Now, what I want to do is take this off the screen and just move forward to what has been called by somebody, I have forgotten whom, the emergence of the DMA Canyon report in 2018. Now, if we can go to your statement, page 212. You describe receiving a contact from the medical director at 8:30 a.m. Is this a phone call or an email?
A phone call.
And did she tell you anything substantive about the content of these reports?
She told me that she had briefly looked at them, and she was concerned that there had been a number of issues detected in these reports. I think she mentioned to me at that point something about uncapped pipes.
Did you ever have a substantive conversation with Dr. Armstrong about what was actually said in the reports?
Just this phone call.
But nothing since then?
No,
And you then went and got the reports,
I did. Yes.
and you eventually received them in an electronic copy as well?
No, I never ever got an electronic copy. I was told they were only available in hard copy, so I had to travel over to the Old York Hill Hospital and pick them up.
Who told you they were only available in hard copy?
I believe it was either Dr. Armstrong or Tom Walsh himself.
Now, on page, well, elsewhere in the statement, I don't think we need to go to it because it's a passing remark. You mentioned your astonishment that people in the water incident IMT knew about these reports and didn't mention them to you. You're nodding again.
Yes.
Who do you think knew of the DMA Canyon reports, who was dealing with you at the time of the water incident, who didn't bring them to your attention?
At that time, I felt it would be estates colleagues and the director of facilities.
And so that would have been whom?
Mary Ann Kane and Ian Powrie and Alan Gallagher.
And if you go to page 215 of your statement, at paragraph 644, you describe what you might have done if you'd been told about it in 2018, but also what you would do about it in 2015. See the first
Yes.
line, you said you wouldn't have opened the hospital.
Yes.
Now, it's been suggested that that's a extreme response, given there were so many other knock-on consequences for services across Glasgow. Do you think you would have succeeded in delaying the opening of the hospital?
I don't think so, but I would have tried.
And what would have been your argument that you would have presented at that point?
Because this hospital was going to be housing some of the most immunosuppressed and sick children and adults who would be at high risk. And I would extend that out to other groups, so all the augmented care units that we were to have, so several ITU beds, I think over 60, paediatric ITU, cystic fibrosis. So there would be lots of high-risk patients in that building.
And you were then the sector, regional
Yes.
sector ICD. Who would you have had to convince?
Professor Williams.
And that was your reporting structure?
Yes.
Right. If we look towards the second half of that paragraph, you see the line that begins IMT in 2018? And you say, I was trying to work out what had happened in this ward system. I was trying to generate a hypothesis. In fact, people in the room had sight of the report, knew exactly what was going on in the ward system and didn't say anything. If they'd spoken up at this point, then we could have implemented relevant control measures very quickly. And we could have removed the children much sooner, which in turn would have prevented infections. Now let's break that down. So what would have been the relevant control methods you could have implemented very quickly?
So point of use filters, but we could have made a start on the chlorine dioxide system.
Because the point of use filters went in within a matter of weeks.
Yes.
So could they have been done any faster realistically?
They could have been, yes, they could have been.
Because how would that have happened? Because there was quite a lot of pushback about testing of them and things at the time, wasn't there?
Yes, so there was a reluctance at the time to use point of use filters. We hadn't really used them in Glasgow before, and there was a suggestion that they weren't necessarily a good thing because they could then become a source by trapping the bacteria of what we would call retrograde contamination back into the system. So there was some reluctance initially to go down that route, really because I think they were unknown and we hadn't used them before. So we had to get portable sinks and other things in place.
You think you would have been a little bit quicker by, what, a matter of weeks if you'd known about it? Right. Then you mention the chlorine dioxide system. How long did it take you to fit the chlorine dioxide system from the start of March of 2018? How many months did it take?
Oh, several. Into 2019, I think.
So more than 6 months.
Yes.
How quickly could it have been fitted, do you think, if you'd had this extra urgency?
Well, we could have at the time perhaps gone down a different route, and we could have gone down a route of what we call shock dosing, which could have been implemented very quickly.
And that would have involved maybe chlorine dioxide, maybe other things?
Yes.
Right. When you say we could have removed the children much sooner, what does that mean? Because when you eventually decant, you don't decant away from the water system, do you? You decant to the same water system.
Yes, that's correct.
So what do you mean by you could have removed the children much sooner?
I don't actually know what I mean with that. Sorry.
Do you think you could have removed the children sooner?
No, I don't think, because where would we have put them? That was the challenge.
Yes, because when you look at Jamie Redfern's options paper for the decant, you look at alternative options, don't
Yes.
you? And they're not very attractive.
No.
No, right. if we go on to the previous page, paragraph 639, you mention at the end of that paragraph, my recollection is April, May 2018, HFS got access to Zootech. I think they came across Intertech and DMA Canyon reports. Can I suggest to you that actually what might have happened is that HFS obtained them from the Health Board in April 2018 via a simple request for documents?
What I remember from that time is that around April, Mary Ann Kane was trying to get documents, which included water testing results, and also the risk assessments were mentioned in an email. And I'm sure at Water Technical Group, she was referring to Ian Storer interrogating Zootech, and she'd given him access to see if he could find things.
Right.
And then when the medical director phoned me, she mentioned that HFS had found things. So I think that's why I say I think. I don't know for sure.
Is it possible that all of those separate facts are correct? It's just that the connection's not right, in the sense that Mr. Storer might well have been interrogating Zootech.
Possibly.
HFS
yes.
might have found them.
Possible.
Mary Ann Kane might have been looking for them, but they didn't find it on Zootech.
That's possible.
Right.
Yes.
Now, if we can go to bundle 27, volume 8, document 32, page 180. No, that's definitely the wrong place. Page 120 of that? Yes, right. So this is from September, early September 2018. Can you explain what this email to Mr. Walsh might be about, what these triggers are? Because this is a time you're not involved in this conversation, but you're involved as lead ICD, and I wonder you might be able to help us understand what this. I didn't put it to Mr. Walsh.
So I recall discussions with Annette Rankin as to what would trigger a new IMT. And I think the view was that any case should be investigated by the IPCT, but not necessarily trigger an IMT. And I think we set a trigger at what's listed there as 2 cases in 14 days for an IMT.
Right. So this is them just effectively reporting that they reverted to those established triggers on the 6th of August.
Yes, so there is reference to me deviating from that trigger in that I triggered at 2 different organisms.
I just wondered why this matters. Obviously, you have to ask Sandra Devine, but I wonder why it matters.
It reads to me potentially that she was disagreeing with me.
But this is a matter of a couple of weeks before the decant decision.
Yes.
Right. Now, if I take that off the screen, we've discussed biofilms, which I was going to do at this point, so we can pass over that. I'd like to turn to an email exchange with Mr. Hoffman. So if we go to bundle 14, volume 2, page 140. So is this the final email in the exchange between you and Mr. Hoffman on or around the 16th September? Which is the day before the decision on decant.
I believe so, yes.
Now, what I'd like to do is go to the beginning, because it makes it so much easier to understand what's happened. So if we scroll downwards through the document, we get to page 147, Kind regards, Teresa. So we see the email is above that on page 146. And you see in the middle of that page, there's a discussion about aerolization.
Yes.
Right. So what was your concern about aerolization at this point?
So when faced with this issue with the drains, I started doing a lot of reading of literature around potential routes of transmission and how that might happen, because that was, I think, one of the sort of questions that kept coming up at the IMT. So people understood there was a risk from the drains, but people couldn't understand how it was getting from the drains to the patient. So I was doing a lot of reading, and I came across papers that were suggesting aerosolization.
So what would that have involved if it had happened? So what is aerolization?
So basically it's how the bacteria are released from the biofilm. And well, the thinking on this has all changed, but at the time there were different sizes. So droplets were larger than aerosols. So I'm talking about the smaller particles.
Right. So you thought they were being thrown up by the drains?
Yes.
Right. Did you get a reply from Mr. Hoffman that starts at the bottom of page 145?
Yes.
We go down to the bottom of the page. Sorry, 143, my mistake. The bottom of that page, please. Yes. And in essence, is Mr. Hoffman responding by saying that effectively it takes a lot of energy to generate aerolization?
Yes, yes.
And over the page, he says he doesn't see activities related to sink use or cleaning as having the energy input to produce significant aerosols.
Yes, that's what he's saying.
Did you understand that at the time?
I understood what he was saying at the time, yes.
Yeah. And if we go right to the beginning of the final message in the email, well, that'll do for that bit. So basically, we've had that email thread. It's a very long email thread. And would it be fair to say that he's disagreed with you about the hypothesis that aerolization could have been an issue?
Yes.
Right. And if we go to the IMT on the IMT that immediately follows this, which is Bundle 1, Document 38. So this is the 14th December. This is before you contact him. You're actually, your intention to contact him is mentioned in the IMT minutes, isn't it?
Yes.
Yeah. We go to the next meeting, which is Bundle 13, Document 39. And that's the IMT on the 17th of September. So that's the day after the email thread ends. And we see over on page 171, you're narrated in the minutes. And of course, you're chairing these, so you can make sure the minutes are right.
Yes.
Yeah. That you'd spoken to Mr. Hoffman, and in his opinion, you should not have to clean the drains continuously. Underlying risks should be resolved. He was concerned regarding the risk of dispersion of bacteria by cleaning, and he was sold to see our drain cleaning SOP. There's no mention here of you telling the IMT that aerolization's off the table, is there?
No.
Why didn't you tell the IMT this?
Because as an infection control doctor, it's not about which route is the most likely. If any of these routes are possible, then you're going to target your interventions for them all. It doesn't matter that it's predominantly aerosols or predominantly droplets, and we can, debate that. And there was different views in the literature around this. It's about making sure you target all the routes of transmission. So I expect I didn't raise it because I didn't want that to be the focus and people to forget about droplets and splash into surrounding areas, that sort of thing.
I suppose this is one of the problems with IMTs is that how many people in that IMT had the technical knowledge to go away and have that conversation with Mr. Hoffman and, as it were, have it as something close to equals?
I would say very few. Potentially colleagues within HPS and HFS.
But equally, how are the estates people, particularly in this meeting, who aren't infection control trained, or maybe even the treating clinicians, supposed to react when you say, I'm going to speak to Mr. Hoffman and get his views, and then you don't report back all his views?
I think it's more than just his views. So his background is engineering, and that's where he is coming from. But from an infection control perspective, I am more concerned about routes of transmission and blocking those, if you see what I mean.
So you're more concerned of the output rather than the explanation?
I'm not, I knew at that point that there was debate as to whether it's aerosols or droplets. For me, the fact that both could be potential, I have to target both of those routes of transmission.
So that Mr. Hoffman's advice doesn't prevent you from, you still have to do whatever you would have done.
No, I mean, it's advice, and, he's always available and very good at giving advice, but I guess it's up to infection control doctor to assess that, and it's not just about the engineering aspects, it's the whole picture. And the other thing about this is Mr. Hoffman hadn't seen the condition of our drains. These weren't normal drains by any means.
Right. I'd like to just check on one document before we move on, which is we had some evidence from Miss Harvey Wood and Dr. Peters about them doing a presentation to the hemato-oncology consultants in June or July of 2018, and then had them producing a report in October. Did you ever see that report?
I did, yes.
Right. I just wanted to check that because we'll come back to epidemiology later. Now, I think where we are, just a moment or two before 4 o'clock, and I'm going to look to his lordship and see whether we want to start on the story of the decant or wait until tomorrow.
I'm really in your hands, Miss McIntosh. I don't want to sit unless there's reason to do so long after 4 o'clock, but if you can sort of take a useful step in 10 minutes.
I'll try and do that.
Please do that.
So, Dr. I'll try and get a little bit way down the journey. What I want to do is, we've got a period between, I suppose, Sandra Devine's email, which we just looked at in early September, and the decant, actual decant, 26th September.
Yes.
What would you characterise the mood of the IMT and the meetings you had with executive board members in that 2 or 3 week window in respect of you and your work?
I think the IMT, there was obviously a lot of anxiety about the risk in the unit. We were not on top of the issues with the drainage system, but equally there was anxiety about moving patients to a different ward within the hospital. We didn't know at that point what time it would be, so there'd be clinician anxiety at the IMT. In terms of the sort of executive group, I do remember going to a meeting. Myself and I think Kevin Hill gave an update on the situation and that the IMT were essentially recommending a decant. I remember them asking for more information before they made that decision. Particularly they wanted more information about the drainage system and the extent of the problem with the drains. I remember them tasking the infection control nurses to go and inspect most of the hospital in RHC to check the condition of the drains. So it wasn't an immediate decision, it was delayed because they wanted more information about the drains.
So before we come back to whether that was, from your point of view, the right thing to do at the time, and I just probably just connect this all to the dates. So let's look at an IMT on the 14th of September, which we've already been to actually, which is Bundle 1, Document 38, page 164. So that's at 1 o'clock, and you're in the chair.
Yes.
I noticed, for example, that Miss Rogers and Jamie Redfern are present, but then they have responsibility over the paediatric patients. I noticed that Susie Dodd's the lead ICD. Have I got that right?
Susie Dodd was
ICN, sorry.
lead ICN, yes.
Yes. We've got Mary Ann Kane from facilities.
Yes.
Dr. Kennedy is here from public health.
Yes.
Annette Renke from HPS. Mr. Walsh from the ICM.
Yes.
Pam Riandes, what role is she performing at that point?
Pamela at that point, I think, may have been a nurse consultant.
And then Sandra Devine is the associate nurse director.
Yes.
Karen Connolly, she's from facilities.
Facilities.
I don't know Miss Taylor. Mr. Hill, now he's...
Director of Women's and Children's.
It's his function that you're discussing, effectively.
Yes.
Right. I don't know Miss Thompson or Miss Cook or Mr. Wilson or Miss Howard, but And Callum is there with the minutes, as always. Now, what I want to understand about that is at the end, if we look at this meeting and we go to, is it after this meeting that you have the meeting with, that you go with Mr. Hill to meet some senior people?
I think so. There is a summary of that meeting from Tom Walsh.
There is,
which
and
would
that's
be
bundle
dated-
27, volume 7, document 8, page 241. Yes, if we go to the next page, so if we zoom out, so we've got the whole page. Now, is this the meeting you've just described where they
Yes.
wanted information about the drains?
Yes,
And that's in the afternoon, I take it?
yes.
Right. Now, this meeting comes up with some actions.
Yes.
Now, is this meeting effectively doing what you would wanted the executive control group to have been doing all the way along, but in an ad hoc basis?
Yes.
Right. Now, what I'm getting the impression from the action points is that there's a requirement to examine the drains as you described. Why would you need to examine the drains? Because presumably you've done this already.
Not further back though. Very superficial of the examination of the drains that only we could see. But not, this refers to putting a scope down the drains and looking further back within the drainage system.
How would the infection prevention control team, all the nurses and Sandra Devine, be able to put a scope down drains? Is that something they have skills for?
No. That would be an external contractor.
Right.
It says endoscopic review of the drainage system. That's what that means.
And then at the bottom of the page, we have entries that discuss a 4-week period and a 4-week time frame.
Yes.
Is that the anticipated length of the decant? Or that the decant will happen in 4 weeks' time?
Initially, the decant was planned to be very short, so it may indeed refer to a short decant.
Now, in Dr. Kennedy's evidence, he describes going to a meeting after the 14th September IMT where this sort of conversation is taking place. Was he at this meeting with you and Mr. Walsh?
I don't remember him being there.
Because might there have been a later meeting over the weekend? Are you aware about whether there was another meeting?
I can't recall any other meeting.
So the reason I'm wondering about this is if you look at the IMT of the 17th September, that's bundle 1, document 39, page 169. So this is the 17th September, 1 o'clock again, roughly the same people are here. But if we go to the bottom of page 171, is this describing the same output?
I believe so, yes.
Right, okay. Maybe
Yeah.
I'm just seeing things that aren't there. From your point of view, looking at the decision then, what did you think of the decision to wait for an endoscopic test investigation of the drains?
I suppose what we were suggesting was a fairly big step to decant children, so I could understand the need for further investigation, and I suppose to be absolutely sure that we were doing the right thing. I wasn't sure what that was really going to add though, because I could see the problems.
I suppose the context partly, there's Mr. Redfern's options appraisal, which I don't need to put on the screen, but I'm assuming you saw at the time.
Yes.
Right. So some of the options there involve going to different locations.
Yes.
You're nodding again.
Yes.
Building a temporary hospital ward in the
Yes.
car park, courtyard. So those are going to take some time to bring in.
Yes.
But moving elsewhere in the hospital could be quicker.
That's correct.
Right. So at that point, what's your attitude to the importance of speed? Is it something that should be encouraged, or is care and time the primary thing here?
I felt it should be encouraged, but I appreciate that it's, a major undertaking to move a ward, and that does require careful planning. So the other side of that is that we needed to identify an area, but we needed to make sure that area was safe. So We can't just move children straight away into a ward. We had to do some work in that area that was chosen.
If you think about the options paper and the range of different options and this context of all the issues you've described, are you comfortable with the decision that was ultimately made to move to what became 6A?
I am, yes.
How do you react to the suggestion that one of the weaknesses of that is you're effectively moving elsewhere in the same water system?
So there were some advantages to moving to 6A. We were able to decant the higher risk patients into Ward 4B, into the BMT rooms there. Ward 6A was slightly different in that it didn't have the trough sinks, which had been recognised as a risk. It also did not appear to have the same issue with the drains. I don't know if that was because they were higher up the building. I don't know if that relates to workmanship, but the drains were not in the same state. And we didn't have, and it was a disadvantage for the children, we didn't have the playroom or the classroom, which had these small sinks with a lot of splashing. We had adult-sized sinks, which brings other problems, but there was less risk in moving to 6A. There was still risk, but there were some features of
So you
6A.
think that some of the features that caused the risk in 2A to be larger weren't present in 6A?
Some of them, yes.
Did the fact that you were moving to a general ward with 3 air changes an hour play any part in the decision from your point of view?
It was obviously a risk, but they were in that same sort of ventilation strategy there. And I think because the drains weren't in the same condition there, I was less concerned about this issue with potential aerosolization and inadequate dilution.
Right. Now, I think we can get to a moment of decision by looking at the next IMT, which is the IMT of the 18th of September, which is in Bundle 1, document 40, page 175. And if we go on to the next page, and the next page, stop there, please. We see in the middle of the page, heading 6, contingency decant, we get the report back from Grant Archibald.
Yes.
So I suppose my question is, who made the decision to decant the patients out of Ward 2A?
Ultimately, I believe that was the chief executive, but based on a recommendation from the IMT.
And would you have ever seen the minute of the water review meeting on the 18th of September that morning?
No.
No. Would you have been aware of that meeting?
I don't know anything about that meeting.
Given that this is a Tuesday, and the previous day the IMT has been told about what looks like the meeting you were at with Mr. Walsh on the Friday, that we're going to wait for the drains
Yes.
to be inspected. Can you help us? So were you told of why there was this 24-hour change of heart by whoever's making the decision?
No.
Did anyone give you any explanation?
No.
No. Was the drains ever examined with endoscopes?
I was told that they were, but I never saw a report.
Final thing about this is that when we look at the minutes of the water review meeting, we see that Mr. Walsh attended it, the one that made the decision. Is there anything that we should think about the way that infection prevention control works? That the manager goes to this board level meeting, but no one tells you what the discussion was?
Yes.
What should we draw from that?
It's a concern, particularly as I was the lead ICD and the person chairing the IMT, so I didn't know these meetings existed until I saw them in the bundle. I would have expected to have been there. I think that I would have been the person that could have given the most intelligence about the situation to the chief exec and the HI exec lead, because I had the relevant expertise.
I think, my lord, this is probably the right place to stop.
Yeah. We'll do that, Dr. Inkster. Can I ask you to be back tomorrow for 10 o'clock?
Thank you.
All being well, we'll see each other tomorrow at 10. And until then, have a good afternoon.